Okay, so pediatric heart failure basically most oftenly caused by congenital heart defect and cardiomyopathy. Heart failure means basically unable to meet the metabolic demand lah of the body. The heart cannot pump enough blood to meet the metabolic demand. So the compensation of heart failure in children, they increase their heart rate lah. That's why the sign is tachycardia. Okay, and then secondly, they increase the contractility and increase the preload lah. Alright. So in pediatric heart failure, can be caused by numerous etiologies. 69% of the heart failure is due to congenital heart defect. The rest can be due to cardiomyopathies lah. So infant account for 60. Basically, the largest group is your infant lah because of the congenital heart defect. Myocarditis also quite common in infant. Other than that, congenital heart defect, cardiomyopathies can be caused by anemia or quite rare infection like your myocarditis and certain drugs lah. In our center, because it's a oncology center, those anthracycline group like doxorubicin, daunorubicin can cause cardiomyopathy as well. And last but not least, your arrhythmia, because if your heart SVT in a prolonged state over time, the heart also become failed over time. Alright, if not treated. Okay, the complexity and pathophysiology of pediatric heart failure, it can be between your circulation, neurohormonal, at molecular level and genetics level. So there are two main mechanisms: volume overload or pressure overload. Okay. Alright. So then another group, the complex congenital heart lah. Alright. Okay, so congenital heart defect, they can cause heart failure. Basically your large defect lah, your PDA, VSD and ASA VSD. The obstructive lesion, severe aortic stenosis or severe coarctation. Then total TAPVD can cause heart failure. Alright, cardiomyopathy is another common cause of heart failure in children. Out of all these four, the most common one is still your myocarditis lah. Most of the time is viral etiology. We have one now in PICU, CMV myocarditis. How old lah? 4 months old, 3 months old. Well, previously, no history of anything, never admitted before. Internally normal, postnatally no issue. Good weight gain. Developmentally probably up to age. Then suddenly develop sudden onset of URTI for 5 days, and day 5 develop more tachypnea. Given nap, typical. So after given nap, heart become more tachycardic, collapse lah. So need intubated and sent here lah. So when they do the echo, the heart is so dilated lah. So and then severe heart failure. So we started patient on IVIG lah to fight off the antibodies from the virus. Then on top of it also give ganciclovir lah, even though it helps or not is two different story lah, but we still give anyway. Okay, HOCM probably in infant of diabetic mother. So patient got mother got diabetes, HOCM is quite common, and that one in good prognosis. Over time it will resolve, but HOCM but no diabetic, then that one probably will be permanent lah. Restrictive cardiomyopathy is very rare. I have probably seen one. Then anthracycline induced cardiomyopathy is still common in our center lah because of the prevalent use of your anthracycline group. Alright. Okay, so you can use your modified Ross Heart classification. You can use your New York Heart Association punya classification. It doesn't matter. Alright, so the symptom, this is just the repetition of what I said earlier. No need to go through it again. Tachycardia, tachypnea, respiratory distress, dyspneic apex beat, bivessel lung crepitation, and hepatomegaly. The edema is very later or very severe heart failure. In big children, yes. One of the patient that just passed away early this year, heart failure due to severe mitral valve prolapse. She has quite significant ascites and edema lah, but because we are unable to repair the mitral valve, and then it become chronic heart failure lah over time. So this kind of patient, chronic, baru they have ascites or edema. Okay, then there are big children lah rather than small babies. Okay. Alright, so investigation, you do your ECG, ST segment to see ischemic heart disease due to coronary artery anomaly. Al-Kappa stand for anomalous left coronary artery arising from pulmonary artery lah. So basically your pulmonary artery, instead of arising from aorta, it arises from pulmonary artery. Okay, this patient that I've said earlier, the 2 months old datang with cardiomyocarditis, very dilated, one of the differential you have to rule out is Al-Kappa lah. So we really look hard for the origin of your coronary arteries. Okay, so chest x-ray will show cardiomegaly, increased pulmonary vascularity. Echo basically to rule out structural defect lah, and on top of it to assess the cardiac function, the LV function and RV function. Alright, so cardiomegaly, this one you do your cardiothoracic ratio, probably about 0.6, 0.7. You measure lah, okay, and then on top of it je plethoric lung field. So cardiothoracic ratio of more than 0.6 is cardiomegaly. Okay, ECG. So ECG in children same as adult, but there is some exception, because pediatric population they are RV right-sided dominant, so your axis is more right-sided lah, but the rest are the same punya interpretation. Okay. Okay, so echo. So this is how your heart looks in echo. In adult, the image will be upside down. In pediatric, we will invert the image, so it become anatomical lah. So this one, mana right side, mana left side, so a bit confusing already for me. Okay. Alright, so management heart failure for non-pharmacological fluid restriction. You give oxygen if patient admitted, and high calorie diet lah, because if you don't give enough nutrition, they use their resting energy to fight off the heart failure. Okay, if you don't give enough nutrition, then the weight loss over time will happen lah, even though they don't do much activity, because the increased energy demand lah due to heart failure. So you need to give very high calorie diet lah. So I advise them to take a patient orally, and some of them in babies we do rice tube feeding lah. So you don't want them to waste their energy sucking. Okay, so rice tube feeding is one of the method to bypass the sucking. Okay, so anti-failure medication need to know very well your diuretics, your loop diuretics, your spiro, and then angiotensin inhibitor, which is your captopril, enalapril and all that lah. All this angiotensin inhibitor will reduce your afterload. Okay, so that the heart will pump against less resistance lah. Inotrope is patient admitted. In the patient that I've mentioned earlier in PICU, we started patient on Mirinon. So Mirinon, one of the medication to reduce the heart preload and afterload. Okay, so that they can pump better lah. Alright. Okay, so we finish about congenital. So just 3 more problem, your acquired heart disease. Kawasaki. So everybody should know about Kawasaki. So what are the 5 criteria? First thing, fever kan? Fever for how long? 5 days plus
more than 4 of the criteria.
So the 5 criteria, which is your eyes, non-purulent conjunctivitis, peripheral changes lah, can be swelling first before they discriminate. Okay, strawberry tongue, your mucosal changes, rashes, polymorphous rashes, sama cervical lymph node lah. Cervical lymph node can be single, can be multiple lah, they're all quite big lah, not shorty, not small one. Alright, because some of the Kawasaki may present as single nodes and have very high grade fever, people also mistaken it as lymphadenitis. It can be present, present that way as well. Alright, and then mucosal changes, not just strawberry lah, it can be your lips as well, it can be the perianal. So in small children, they will have perianal scoriation. And then on top of it, don't forget the supporting punya features like your BCG flares. Alright, okay. So basically the most common acquired disease in the world lah basically. but the problem, the vasculitis happen at the small to mid-sized arteries lah, which the basically your coronary lah, the small arteries. So inflammation at coronary arteries will cause this problem at the layers of your coronary vessels. So it will cause inflammation, then over time it become aneurysm lah kalau tak treated properly. Okay, this is the criteria. The lymph node is about more than 1.5 cm lah, not the small one. Okay, alright, so strawberry tongue, don't forget your fissured lips or red lips as well. So before they become peeling, they will have swelling first. Okay, edema first. Peeling is a later signs. Okay, alright, so there is red eyes, red lips, cracked lips and red tongue. They are very diffusely red lah. Okay, BCG flash as well. The ears also, the pinna also can have redness as well, and perianal escoriation. It's already hand swelling here, a bit of peeling at the pinna area here. Okay, so there are multiple phase. Basically the acute one is the fever. Arthritis may come about at the end of second week. Your myocarditis can happen during the mid first week. Skin changes will happen at the end of first week. Mucosal changes will happen during early phase and mid week. Cervical adenitis also during the first week. So thrombocytosis only develop bit later. Okay, so we have a 1-year-old presented to us at day 18 of fever. Day 18 of fever with thrombocytosis of 1000. Okay, so already treated in private up to day 8, then discharged AOR. Somehow didn't diagnose Kawasaki yet. So given TCA, come for TCA, given antibiotic, blah blah blah. Still fever not resolved, come to our emergency, admitted. Okay, so just do the echo lah. We're already day 18. When we look back at day 18, they don't have all features at the same time. Some of the features already resolved. Okay, but you have to take retrospective history at day what got what symptom. Okay, if then somehow this child 4 out of 5 positive, so we do the echo, already too late lah, your coronary already blown up so big, and not just one coronary lah, all 3 coronaries blown up. Okay, so aneurysm at all 3 coronaries artery. Okay, but despite that we still give IVIG because CRP still on the high side and fever still not like fully resolved. In Kawasaki, if you don't treat it, is self-limiting, so the fever will resolve by itself, but the problem, the complication lah, because if the inflammation is very severe, then you will have coronary artery aneurysms. Okay, so you send your FBC, we show anemia. The severe one will have anemia, HbA on the low side, raised white cell count, and thrombocytosis lah. Thrombocytosis only happen a bit later. Some of it also may have thrombocytopenia lah, the atypical features. ESR will be raised because the inflammatory state. Liver function, because of the inflammation, doesn't just happen at your heart, it happen also at the rest of the organ. So if the inflammation at your meninges, they will have meningitis features lah, which is they are very irritable. They irritable because of meningism, they irritable because of high grade fever as well. Okay, but you do the LP, they will be aseptic lah, mean no white cell count at all, and culture is sterile. If you do liver function, your transaminases will be raised because your liver is inflamed. If you do ECG, it depends on the problem lah. If you got thrombosis, you see the ischemic changes. If just myocarditis, it's only tachycardia and dilated ventricle hypertrophy and the right side or left side lah, depend which side is dilated, most likely the left side. Okay, then do echo to assess the coronary artery. Okay, but nowadays we want to treat Kawasaki by day 7 lah. Previously up to day 10 we can still give IVIG, but the studies shown that day 7, day 8, day 9 onwards, the highest prevalence of coronary artery happen during that time. Okay, so by day 7, if fever still persistent, very high grade, Kawasaki fever always 3940, 3940, don't go down very easily. Okay, so if high grade fever by day 7, do the echo. if got changes, you treat lah. If 3 out of 5 criteria positive, you treat with IVIG, then refer later. Doesn't matter lah. If 2 out of 4, 2 out of 5, you do your there is the guideline lah. Do your CRP, do your ABC, look for other features lah. Send your urine, do your ultrasound or whatnot lah. Okay. Alright, so management we give IVIG. The key word here basically high dose IVIG lah, which is 2 gram per kilo. High dose means 2 gram per kilo lah. If 1 gram per kilo, 0.8 gram per kilo, that's not high dose lah. That one is just normal dose. The next thing we give aspirin, high dose as well. High dose basically 30 to 50 mg per kilo. And then aspirin 3 to 5 is anti-platelet dose lah. So these two basically is to reduce the inflammation. Okay, IVIG will fight off the antibodies and also reduce your inflammation. The aspirin inflammatory dose reduce inflammation. Here is said anti-febrile lah, but different center, different practice. Here we probably give until appointment 2-3 weeks later, because the aneurysm may happen a bit later during the second week, 3 weeks onward. Okay. Alright, so if patient got thrombosis, we'll probably add on warfarin and corbidecrol lah. Those with small aneurysm will need 2 antiplatelet lah. Those with giant aneurysm will need warfarin. Okay, because the larger the aneurysm, more likely they develop thrombosis. Okay. Alright, so rheumatic heart disease, basically another acquired heart disease, but it happen in the low financial group rather than the T20 and M40 lah, more of the B40 groups lah, because of the poor hygiene and all that. So throat infection, later on we develop antibodies. The antibody will attach to your mitral valve lah, mostly will cause mitral valve regurg over time. Okay, so the heart failure due to the myocarditis and the heart failure due to the severe mitral regurg. Okay, sign and symptom, you have to remember the modified what score? Alright, Jones score. Okay, so fever with arthralgia or arthritis, fatigue, chorea, jerky uncontrollable movement, and painless nodule at the skin near the joint, and the pink ring at the with the clear center. Heart murmur because of the mitral regurg. And then symptom of heart valve damage include your chest pain, shortness of breath, basically your failure symptom as well, the fatigue and rapid and irregular heartbeat. Okay, so investigation for rheumatic heart disease, you send your ASOT, ESR, chest X-ray, ECG, the standard. But the one specifically here, basically ASOT lah, you want to diagnose your group A, group Streptococcus. Okay, management, anti-inflammatory, you give high dose aspirin as well, and you give steroid on top of it. On top of it, you give aspirin as a maintenance and penicillin to fight off, to clear the streptococcal infection, and you manage the heart failure lah. So once they are out of the acute phase, they will need prophylaxis, either monthly injection or daily oral penicillin. Okay, if allergic to penicillin, we give what? Erythromycin lah, your macrolides. Okay. Alright, I think this is the last one. Myocarditis, basically it's a serious medical condition with high morbidity, high mortality lah. It's initiated by a number of agents, including your viruses, bacteria, parasite, and drugs. Okay. It is a spectrum of illness, can be very mild or can be very severe lah. Those yang very severe come with the cardiogenic shock that I've mentioned earlier. Basically, the commonest cause of heart failure in her previously healthy children. Okay, so investigation is the same, not much different from the previous punya problem. Same thing as well, you treat the heart failure, treat the underlying infection, give IVIG. So the drugs are always the same. It's either your anti-failure or give IVIG, aspirin, maybe plus on and off steroid. Okay, alright, that's all. Any question?
Doctor, why do we check for ESR